Welcome everyone. Today's webinar, Driving Healthcare Access, Mobile Health Clinics as a Vehicle to Address Health Inequities. First, I'll go over some housekeeping items. Make sure that you're connected to audio using your computer speakers. All attendees will be muted during the webinar. Ask questions using the Q&A feature. If you have any comments, you could use the chat box. We will be taking questions throughout the webinar. If you have any technical difficulties, please email support@healthliteracysolutions.org for assistance. The webinar will be recorded and posted in the Health Literacy Solutions Center webinar archives. Following the webinar, you will receive an email containing a link to a brief online evaluation. If you are requesting continuing education credits, you must submit an evaluation in order for you to receive your CE certificate. So with that, I would like to turn over this presentation. We're so excited to have this group on board, and I'm so excited for this presentation, and I hope you are all as well. I would like to turn it over to Dr. Ethel Ulrich.
Welcome, everybody. On behalf of my co-presenters, we are so excited to be presenting on this very passionate topic. With me today, I have Dr. Patrick Deneen from the Mobile Mammography Program at Stony Brook Medicine in Ronkonkoma, New York. I have Angela Malone, who is the Coordinator of Clinical Services at Malloy University, Rockville Center, New York. I have Dana Sanneman, Vice President, Public Affairs and Development from Mount Sinai, South Nassau in Oceanside, New York, and myself, Dr. Ethel Ulrich, Associate Professor and Director of the DNP program in the Barbara H. Hagan School of Nursing and Health Sciences at Malloy University. Next slide, please. So today, what we're hoping is that as a group, you will be able to gather a lot of great information from this webinar. And at the end of it, we're hoping that you'll be able to identify common barriers, at least 3, to assessing medical care at a traditional healthcare facility and explain how a mobile health clinic addresses those barriers. Discuss the importance of effective communication to engage patients and gain their trust in mobile healthcare settings, and identify at least 4 issues to consider when launching a mobile health clinic. Next slide, please. So I'm going to let you know that we're going to be providing a brief overview of mobile healthcare clinics. And then we're going to be giving you examples of 3 diverse mobile clinic projects here on Long Island, from Stony Brook, Mount Sinai, South Nassau, and Malloy University, and how mobile health care clinics can address barriers in access to care and to communicate effectively with community members about a mobile health program. And then how do you launch a mobile health care clinic? And then we will entertain some questions and answers. So before I move on to the next slide, I'd just like to say that the COVID-19 pandemic has really changed our world, and it has changed healthcare as we know it. And it has also shed a light on those healthcare disparities and inequities that have been with us for quite some time. And they are present in our society, and they need to be addressed. And in fact, COVID-19 has dramatically amplified the dire effects of disparities with respect to social determinants of health. And patients in historically marginalized groups not only have significantly poorer health outcomes, but also lower prospects of accessing high-quality medical care. Mobile health clinics represent an untapped resource for our healthcare systems. These clinics provide access to healthcare for historically marginalized, displaced, or isolated individuals and offer versatility in the setting of a particularly stressed and inadequate healthcare infrastructure. And as a long-standing community-based service delivery model, it really fills a gap in that healthcare safety net. Delivering care into the heart of a community reduces barriers to care, such as transportation, childcare, cost concerns, perceived or actual intimidation by traditional healthcare, hours of operation, etc. And so this panel brings together 3 different models of mobile healthcare delivery to share our experiences with you, our lessons learned. Next slide, please. There is a growing body of literature that supports mobile health clinics. They are successful and they are cost-effective models of healthcare delivery, uniquely positioned to access and fulfill the needs of underserved populations. Through the act of literally driving into a community and opening up our doors on the community's doorsteps, we reach our target population, and mobile clinics have been shown to be able to engage populations and gain trust, especially with vulnerable populations. Because mobile health clinics can overcome many healthcare barriers, services provided by mobile healthcare clinics have been shown to improve individual healthcare outcomes, advance population health, and reduce healthcare costs compared to traditional clinical settings. And this was a quote by an article in the International Journal for Equity and Health. And if you haven't visited that journal already, you should. It's a wonderful journal. Okay, next slide. So we want to get to know you a little bit, and we're going to try to do this best we can in a webinar format. So I'm going to ask you if you can tell us in the chat function what your role is. Are you a nurse? Are you a physician, a health educator, another healthcare professional, a student? Pharmacist and chef, I love that. I have 1 response so far. Let's see some more. Nurse, health educator, postdoc in health services, nurse, nurse navigator, nurse, great, community healthcare worker, health educator, nurses. Nurses are representing today, public health professional, program manager, and clinician, consultant on Vax Confidence, wonderful, community outreach coordinator, public health professional, patient advisor, project manager from mobile screening unit, wonderful, public health professional, again, manager, patient. Okay, so we have a really nice diverse group of people on the presentation, and that will help us moving forward. So thanks for participating in that. Next slide. And one more thing I'm going to ask you to put into the chat. So some of you already did, but what is your current involvement with a mobile clinic? Are you just curious? Are you in the planning stages, which can be overwhelming? Are you currently operating a clinic or other? So I have somebody in the planning phase, I see. Planning phase, wonderful. That's good to know. Curious and planning, great. Somebody from Stony Brook, wonderful. Operating a cancer screening, planning phase, okay. Curious, all right. All right, I think that's it, so great. So I think this will be helpful to you, especially in the planning phase. Okay, next slide, please. So just some statistics about mobile healthcare. In the United States, there are approximately 2,000 mobile clinics that operate, and this serves an estimated 7 million at-risk individuals each year. Of course, these clinics come in many sizes and configurations: buses, vans, RVs, trailers, and the 3 clinics we're going to talk about today are also all very unique and a little bit different. services overall for mobile healthcare range from preventative service to chronic care to primary care, urgent care, and then specialties such as mammography, dentistry, pediatrics, and COVID-19 vaccines. Mobile vans play a critical role, in connecting patients to additional care with those referrals. And in general, 39% of the mobile healthcare clinics serve only in cities, 14% serve only in rural areas, and then 47% serve both in rural and urban locations. Next slide, please. So how did we get to mobile vans? So looking back at the history, in the 1930s, 40% of doctor-to-patient visits occurred in the home. So it wasn't at point of care. Physicians were going into homes where patients lived. And it's interesting that things are turning the tide now and that home visits are becoming much more popular by clinicians. And in fact, there's a movement to have hospitals at home also. So interesting, moving the care to where the patient is. Then in the 1970s, Kaiser Permanente and Nassau partnered with Arizona's Papago Indian Reservation to test the practicality of an emerging field at the time, telemedicine. Again, thinking if we bring the care to where the person lives, where the patient works, where they play, we'll be better able to reach people. So it's interesting how telemedicine took such an important role during the COVID-19 crisis also. Again, reaching patients where they live. And another fact that we wanted to bring up was that in 1972, we know the 60s and the 70s, there was a lot of social upheaval. And there was realization at that time that there was health care inequities and disparities. And so in 1972 in Oakland, California, members of the Kaiser Permanente Black Student Nurses Association served on a mobile foot health clinic. And from these early examples, mobile healthcare has really expanded into multiple areas now. Next slide, please. So another survey for you to type into the chat to keep you awake. And, as a clinician, I always focus on healthcare outcomes and quality for patients, but we can never forget about the financial aspects also. And so tell us in the chat, what do you think the average return on investment is for a mobile health clinic? Somebody's already answering. $20, $5, 12. Allison said 12. 12, 20, 5, 10, 12. So 12, 15, 20. I'm glad nobody's putting 0 in there. So I think you're already invested in the fact that the financial aspect is positive. I'm getting a couple more answers. 12. The answer is, next slide, please. For every dollar spent on mobile health, $12 is saved. So those of you who chose $12, kudos to you. You got the right answer. And so that's significant. And estimates show that each mobile clinic results in an average of 600 fewer emergency room visits each year. And on average, each mobile health clinic saves 65 quality adjusted life years every year of operation. Significant statistics here showing the efficacy of mobile health clinics. Next slide, please. So how much does it cost to operate a mobile health clinic? On average, it's $429,000 per year. And on average, a visit costs $155. And yet the savings are 12 times that. So that would be $1,800. Each visit to a mobile care clinic saves on average $200 due to avoided emergency department visits, right? That's a big issue. And each visit saves on average $1,600 due to long-term impact of preventative services, right? If we can swing that paradigm from managing illness to preventing it, how much money we could save and how much healthier our environment would be. Okay, next. And we will answer questions at the end. Okay. Now, as I said, we serve Long Island, and Long Island is a suburban area. It is 118 miles long, and interestingly, features some of the wealthiest and most expensive neighborhoods in the world. Yet, it has been called one of the most segregated suburbs in America, and that is truth. And so you can go from a very exclusive neighborhood and you can go less than a mile away and you can have a very underserved area. And so in some cases, when we look at statistics, according to the Community Health Assessment and Community Health Improvement Plan for Nassau County, the affluence of the county masks the needs of the severely underserved. So we are aiming to get to that population. And when we look at Long Island, approximately 197,000 people are living below the national poverty line, which is staggering. But worse than that, there are nearly 268,000 additional households on Long Island with incomes above the national poverty level, but below the budget calculated to account for basic care needs. So we have areas on Long Island that are extremely needy, they are historically marginalized and need good care. Next slide, please. So now it is my pleasure to introduce Dr. Patrick Deneen. Again, he is Stony Brook Cancer Center Mobile Mammography Program Coordinator since 2019, and he has helped grow the mobile program from a grant-funded to a hospital-owned service, expanding services and programs to include a broad range of cancer screenings. Dr. Deneen.
Thank you very much. We could go to the next slide. Dr. Ethel Ulrich, you brought up so many great points. Thank you for inviting me here and for everyone for being here. And all the important points were hit, which brings us to the essence and the need for these mobile programs. And those of you who are in the planning phase and the strategizing phase, we're all here for you, for each other. I spoke to the Malloy staff a bunch when they were in their planning phase, and it's great now that they're up and running. And all the important facts were brought to the surface here, which I'll touch on, and I'll give a broad overview here of our program at Stony Brook Mobile Mammography. Even more importantly is we are here on the East Coast. I know we have some West Coast attendees here. You can tell from some of the New York accents where we are located. Mine, people think I'm from Canada or Boston. I've lived in all the places, so I don't know where my accent's from, but the others on the panel are certainly, the New York accent will come through, and we love it. So this is our mobile unit. We call her Pinky. She is just as pretty now as she was when we first got her in 2019. She weighs a little over 27,000 pounds. She's a 40-foot length motor coach, and the clearance we need for the low bridges is about 13 feet. So she cannot drive on any of the parkways here on Long Island. So our motor vehicle operator is one of the most important people on the staff, because there are those who have unfortunately driven a bus under a low-hanging bridge and have torn the roof off their vehicle, which you will be introduced to if you attend the Mobile Healthcare Association annual meeting and hear all the horror stories. Next slide, please. This is a picture of our Mammo suite inside of our cozy bus. And if you ever are interested in visiting our website and Google searching us, on our van calendar, there is a virtual tour you can take inside and outside of our mobile unit. So it could give you ideas when you're planning your own. Also included in this picture is our wheelchair lift. That's the rear door where there's a wheelchair lift stowed underneath in the storage compartment. And so there's a myriad of programs can cover only the uninsured, screen only the uninsured, and help the uninsured, or help only the insured. And we have a beautiful balance of mixing the two here at Stony Brook. We collaborate with basically everyone we can, businesses and churches and libraries and health fairs and medical offices that don't have a mammography unit, especially a 3D mammo unit, such as the one pictured in our coach, as well as businesses, because the working woman is the busiest woman on earth, especially if she has a family, and because those are usually the most dedicated people in the family, and they're serving everyone and caring for everyone except themselves, right? They're putting themselves last. All the wonderful parents out there and caregivers, you're caring for everyone else except for yourself. So this is to urge all the women to get mammos, all the men to get any cancer screening when you are age appropriate. So when we bring our bus to the units, to the locations, there's no fee. We do provide a screening mammogram for women 40 and over, whoever is due, as long as you haven't had a mammo in the last year, insured or uninsured. Regardless of the immigration status, which is a strong point, because the most important thing that our staff brings to the community is the feeling of comfort and care, and the dedication that our staff brings to those who enter our mobile unit is it's safety. They feel safe. We've screened walking distance from a brick and mortar hospital in Long Island, and who also accept uninsured patients, but the patients prefer to come on the mobile unit because they feel safer and they feel like they're not being judged, and they feel like they're getting a better quality of care just because of how the staff and the mobile unit as a whole makes them feel. As I said, we are wheelchair accessible, and we do have a bilingual staff because probably more than half of our patients do speak Spanish. Next slide, please. Even more importantly, before I forget, especially now with statistics, I'm impressed Linda Billy from Stony Brook did answer correctly 12 times per dollar saved. She's paying attention to every time I speak, and I am very impressed. Thank you, Linda. So here's a great snapshot of within our own. It's always easy to judge other facilities, right? But if we have a snapshot of within our own home facility, we have a brick and mortar breast screening facility, and it's a wonderful location. And here's an example. In the red is our mobile unit statistics, and in the blue is the breast center, Carol Baldwin Breast Center, who actually just passed away, but it's named after Carol Baldwin, and it's a wonderful facility. But the majority of women screened for breast screening, almost 80% of the women at the breast center are white. And on the other hand, look at the majority of patients screened on the mobile unit, and that's the red. Nearly 70% of the women screened in our mobile unit are of the Hispanic descent, almost 10% Black African American, and overall, 71% of the patients seen on our mobile unit fall under a minority population. To date, we've diagnosed 26 breast cancers. We've helped diagnose, because we are a screening program, And from there, the patient goes on to a diagnostic mammography, a biopsy, where they eventually do get diagnosed. And 54% of our patients that we screen are, in fact, uninsured or undocumented. Next slide, please. And so here's the nuts and bolts of this presentation and of our mobile program. The purpose is to bring it to the women who are not bringing themselves to the hospital. Why aren't they bringing themselves? Safety concerns. They don't want to be put on the grid if they are not here legally. They don't feel comfortable. They're not aware, maybe, right? Lack of education, they're not aware to get screened. And so our job, besides screening, is getting out in the community and educating, alleviating that health disparity in the vulnerable populations, the socio-demographic impact, which you saw on the prior slide. What Dr. Ulrich hit on immediately is so important, avoiding ED visits. And someone asked in the chat, who's saving the money? Is it the patient? Is it the staff? It's who's paying for it. And when you have an uninsured patient, for example, coming, for us, we enroll them in what's called Cancer Screening Cancer Services Program, CSP. We enroll the uninsured, and it covers the cost of the breast screening, a clinical breast exam, a pap smear, and a FIT testing for colon cancer. But we fall under the breast screening, and it covers the cost of that, of their diagnostic follow-up, biopsy, et cetera, all through diagnosis where they could get coverage for any treatment they need to cure what's found. And if you have a certain population that does not bring themselves to the hospital, as you saw on the prior screen, they're going to rely on the emergency room as their primary care physician, and they're going to wait until something goes wrong. And if you wait for a visible change for breast cancer, that could mean it's a very late stage. And what's the first place where's the first location they go is the ED. And when they're uninsured, who's covering it, right? The hospital, the taxpayers, the government. And so instead of hundreds and thousands of dollars being spent on a stage 4 cancer, the chemo, the radiation, the surgery, which is all hopefully a life-saving event, we're able to screen them at a much lower cost, at no cost to them, and catch in much earlier in the process. So that's the education part, making sure women are coming to get screened, which is why we want to put this on 4 wheels and bring it right to their community. So our purpose also, increasing access, which is everyone's purpose. Mobile healthcare was the future of medicine, and I believe this pandemic pushed it to be the forefront of medicine, mobile and telehealth, right? And so our goal, ease the minds, ease the intimidation by a scary healthcare setting. There's no waiting room, there's no machines beeping and this and that, and there's no people running around and causing havoc. This is a safe environment, a quiet environment, and with only one patient allowed at a time on our mobile unit, they're getting quality care that makes them feel safe and special. Next slide, please. And to prove the point, we give survey cards, anonymous survey cards that patients could drop in a Dropbox or mail back. They're self-addressed on the other side. And we ask these questions: how was your experience? And it's bilingual. And how did you find our staff? And would you have received the memo if not for this van being here? Overwhelmingly, the answer is no. Meaning if not for our program, they would not have got screened. My favorite question: how likely are you to recommend the program to friends and family? You want those 9s and 10s. That's your net promoter score, right? And that means they're going to spread the word and bring friends and family, which happens all the time, back to visit you. And we get the phone calls. My mom came, my sister came, my friend came. I'd love to come too. My coworker came. And then we have a comment section, which, back to Linda Billy, didn't think I'd be able to read this. But as a matter of fact, I can. And I believe it says, excellent service from the ladies. Very kind. May God bless you. Thank you very much for your service. So this is the positive affirmation that we get to kind of remind ourselves in the daily grind. It's appreciated and the staff's making a difference. Next slide, please. Now I'm going to hand it off to Dana. She's the Vice President of Public Affairs and Development at Mount Sinai South Nassau. She oversees planning, implementation, and synchronization of strategic communications and development programs that combine, she could tell you everything about herself, the positive reputation and philanthropic support of hospital services and programs. So thank you for your time, and we'll talk again in the Q&A.
Thank you, Dr. Deneen. And you really took most everything about what I was going to say about mobile health and the what it brings to community. So I want to just touch a little bit, so I'm not repeating what Patrick said, but talk a little bit more about how we were able to fill gaps here, and also the other benefits of community partnerships, just to add a little bit something different. So I'm the Vice President for Public Affairs and Development at Mount Sinai South Nassau. So for those of you not familiar, we are the Long Island flagship hospital of the Mount Sinai Health Network on Long Island. We are located in Oceanside, which is about 40 minutes from the city, about 15 minutes from Long Beach. We serve about 1 million people on the South Shore of Nassau County, so from Queens out to the Suffolk border. And what Dr. Ulrich said about Long Island being a wealthy suburb, but having pockets of need really describes our community. We're a very blue collar, working class population here at South Nassau, and we definitely have pockets where we have patients with needs. So my bus, 100%, and I call it my bus because it's my baby, but we founded it, we created it, we got it off the ground to serve a very specific need. So after COVID, when the vaccines were rolling out, our local governments out here on Long Island were getting infusions of cash, of CARES Act money to help bring vaccine to communities. And I'm sure everybody remembers at that time, it was like Hunger Games, right? I mean, everyone who was eligible was trying to get vaccines. But there were major challenges for people who did not have access to technology, who didn't use technology. And our former president, who's since retired, really wanted to try to get a mobile bus. So we were able to secure from the town of Hempstead, which is our municipality, our governing municipality, CARES Act funding. And I mean, talk about Hunger Games. I had to go out and try to find a bus when everybody was buying campers and RVs to take their families. You know, you couldn't really travel, to take their families out. I could not find a bus. So I actually had the funding. I had the commitment from our organization. I had staff, but I had no mobile unit. So I actually was connected with a company, Mission Mobile, who basically they turned former units that were used for another purpose into healthcare vehicles. And they said the only vehicle we have right now is a 2013 former mobile command center. It only has about 24,000 miles on it, but it wasn't an accident. So I said, I'll take it. And we had a member of our board who lived in North Carolina. That's where the company was based. And he himself went to the company, kicked the tires, checked the bus, and said, this thing is great. You guys will love it. So we took it, they outfitted it. We had it up here in March 2020, which is right when they were starting to expand the eligibility beyond people age 65, like right on the cusp at that point. And from that point, we've since vaccinated over 12,000 people. We've been operating about 5 days a week. Our staff consists of a nurse practitioner, an LPN, and then we have a rotating group of actually many retired nurses who came back just to vaccinate. We have a registrar, we have a coordinator, and it's all overseen by our Department of Community Education. So for all the reasons that Patrick stated about why these units going into communities are becoming so successful, everything he said was accurate. What we really tried to do with vaccine is to close the gaps in the beginning with hesitancy. And the way that we did that was with education. And the best way for us to get education out was really partnering, using social media and partnering with our local media partners. So News 12, which is our cable Newsday, our newspaper, the Herald, our community paper, and every single time we could, we would invite them to come to the bus. And we had a span last summer where we had a News 12 cameraman and reporter with us every day. They would come, they would do spots, not even necessarily about vaccine, but just about a COVID story, and would have our bus in the background. We would get people flooding to us saying, we saw you, we know that you're in Elmont today. We know that you're in Uniondale today, and we saw you on News 12. So that was really how we became successful, was just using every opportunity with earned media to get the word out there that we had this bus. And the same thing that Patrick said, we don't charge for a vaccine. We don't, no questions asked about citizenship. We had a bilingual staff as well. And we also really we leveraged the partnerships that we had with community groups. So we actually partnered with our friends at Malloy University on a few different occasions. We did an event with them at the MLK Center, just to, we've been to community fairs together, our buses kind of side by side, excuse me, just to really just strengthen these partnerships in the community. We partnered with churches, we partnered with civic groups, any opportunity we can, because it's one thing to roll the bus out, and now the bus is really becoming more visible and people know what it is. But when you go to a church, the Convoy of Hope, for example, where they're having a community event and it's established, you get hundreds of people there, and they're saying to their community, like, this is okay, like, you should go there and get your vaccine, just really made all the difference in the world. We always tell this story. We were in an Island Park, which is an underserved community near Long Beach. And we were in just the parking lot of the train, and we were getting people, and two guys who were working in the deli walked up. They still had their aprons on. And literally this was like their 15-minute lunch break. And if we hadn't been there in the parking lot right by their office, they probably never would have gotten. I mean, you don't realize people when they're working, they have other commitments that they don't come. And then later that afternoon, they actually went down the road to their two friends who worked at the car wash and sent them down. So, really, it's been just a tremendous community outreach. We always kind of wanted, as a department, we always wanted this kind of mobile health bus, but there's always challenges from a healthcare perspective in getting it and having the funding. So we renewed our funding with the town of Hempstead for 2022. The demand for vaccine has definitely gone down, although we've had a little uptick in the past couple of weeks with fourth dose and just people concerned about the new variants. But we're still moving. Our community education team, separate from the funding we have from the town, will often be right along with the bus offering screenings, blood pressure screenings, BMI screenings, those types of things, and we're able to keep moving that way. So next slide. I think I have another slide here. Thank you. So again, we just continue to in the media to tell our story. The story in the top right was actually just a couple of weeks ago, where Newsday was looking to speak to patients who were getting a fourth dose, so who are eligible and getting the fourth dose, and what their reason was. And this woman said she was really looking to travel to go see her family out of the country, and just felt safe getting another booster shot. On the bottom there, we went to some local businesses, again, pizza shops, restaurants, where people just work a tremendous amount of time and really looking to continue to get vaccinated. And on the left-hand side was when we went to Malloy and other colleges, when their students were coming back in January and February and needed boosters to come back on campus and live. I think I have one more slide. So now we've about, I guess, almost a year and a half that we've been going. We have won awards, and I know, Ethel, you'll appreciate this, but our nursing team on the Vaxmobile won the team award for team nursing, the Daisy Award. They're receiving their pins tomorrow. And we've also received a Fair Media Council award for best awareness campaign. So just again, like, it's one thing to have the unit, but it's, you want to use it, right? You want to really maximize every opportunity you have to get out there so people know about it. We're doing a health fair on the Long Beach Boardwalk in a few weeks, and the best thing I can do is just park my 50, no, how big is it? It takes up about 9 parking spots. That's how big it is. It's really a huge, huge vehicle. My boss wants to actually bring it up onto the Long Beach Boardwalk. The city has declined that request, but we are going to bring it as close as we can, just because it's our own mobile billboard for public health. So any questions, I'm happy to answer them in the chat. I'll also put my email address in the chat. If there's any questions after, feel free to reach out to me. But I just like to thank Malloy and Angie and Ethel for organizing this for all of us, and thank you.
Thank you so much. So I'll just go through. So I coordinate clinical services at Malloy. We're at Malloy University as of today. Yesterday we were Malloy College. So excuse me if I say it incorrectly here, but still getting used to it. So everybody's covered a lot of the really, key points. So I'm just going to talk a little bit about how our setup is a little different and some of the unique pieces we bring to it. So next slide, please. That's our vehicle. Our vehicle is only 30 feet long, and that's something we can talk about in the setup. We wanted to, we wanted to make sure we didn't have problems accessing different locations, and so ours is about the size of like a food truck. Next slide, please. All right, so we're funded by a foundation at this point, 100% funded by the Mother Cabrini Health Foundation, which is a New York foundation. And really, we've been tasked with providing no-cost services to low-income residents across Long Island. So for us, this provides certainly a service to the community, but it also provides us with an opportunity to give our students some hands-on experience doing community healthcare and working with underserved populations. So next slide, please. All right, and we pull from lots of different expertise across the campus. So we provide some scholarships to students and bring in faculty supervisors to work with them at the undergraduate, graduate, and doctoral level. And that's from nursing, our speech language pathology students, mental health counseling, social work, music therapy, education. And we've recently brought on some students from our languages and culture department to help with some of the translation out in the field. Next slide, please. And we really try to provide a depth of services. We're doing mostly at this point screening and then referral on, for further care. So blood pressure, blood sugar, BMI, cholesterol. We do some basic stress and anxiety type of screening. And then we provide education and information. So smoking cessation, mental wellness information, and we'll do little mini, talks about things like mindfulness, voter registration, just basic health and wellness education, and then some social emotional learning support from our education students. Next slide. And for events, we're going to a lot of the same places. So we've actually all partnered up at different points in time at different events. The big fairs are great. They've been few and far between these past couple of years because of COVID. I'm hoping this summer it picks up again. But we're really looking for partners that are bringing in, the patients that we're hoping to serve. And for us, if we can kind of piggyback on the credibility and the trust that that organization already has with the people it serves, that's a win for us. So a lot of times the site where we're going to does a lot of the promotion and says, we're bringing in, this mobile health clinic and they can provide you with these services. And it helps us to gain the trust that we're going to see. And our students are getting a great lesson in community health and just learning that engagement is the key. And it's not just if you build it, they will come. We have to really our students learn to walk around here. We're at a fair here, a festival, and walk around, bring people over, talk to them. It's an ongoing effort. Next slide, please. So, and we had to do some adjustments with COVID-19. You can see in the top picture, everybody with their coats on, but we try to see everybody outside as much as we can. Inside a mobile clinic is not the most COVID-friendly, environment for a group of people. So we do as much as we can outside or in a large space. And our education faculty and students actually moved onto Zoom because the school districts didn't want us going into, primary care setting with, little kids and all of our students. So we found some ways to adapt to that. And we're always evolving our, policies around masking and all the other pieces like everybody else. Next slide. And this is a little bit about, so we're just collecting our statistics for, we go by semesters because we are academic. But looking at last year, we launched in June and went through December, served about almost 1,200 people at 32 different locations. Most had high blood pressure and elevated reading. Most had a BMI that put them into the overweight or obese category. Almost half of the hearing screenings we conducted. So the speech language pathology students do the audiometers and test for hearing. Needed further, we referred them on for further evaluation. And about a quarter of the kids that we screened for speech and language development were referred on. And you can see here, we're seeing a very diverse mix of, the population, split among ages and split among races. Next slide. All right, so I'm going to turn over to Ethel to kind of guide us in some discussion, and we'll make sure we're looking at the questions that you're posting too, and we can address those.
Yeah, what I think I'll do first is hit the questions that have already come in the box, and then we'll proceed with that. So the first question is for Patrick. How do you follow up with patients who don't have a home, phone, or access to a computer? For example, how do you mail the mammo results to someone who is homeless?
So, good question. Our follow-up, we contact the patient however we can. If they don't have a phone, obviously, or a home, it's very difficult for follow-up. And we take that into consideration before screening them because the follow-up is key. We don't want a positive finding on a screening mammogram and then leave the patient out, going not having a follow-up. So we do ensure that we're able to contact the patient. If they're at a home, we have the contact for the home where the patient is under the care for. If it's a facility that they're currently living in, the results are usually ready by the next day or two. And then, so we try to get them as quickly as possible. Now, when they need follow-up, especially if they're uninsured, the CSP program contacts the patient or we put the patient in contact with them, however they are able to communicate. And transportation is even provided if they don't have it, and they're going to a facility closest to their location for follow-up treatment.
Okay, great.
And then the second, sorry, yeah.
There's another question for you. You're very popular. So, do you try to visit a location in each zip code of Long Island at least quarterly, annually?
It's a great, you gave me the idea now to put every zip code on the wall and to cross them off as we go. I know we have not visited every single zip code, but we have tried to visit certain pockets of Long Island, especially the needed ones. And how do we know? One, we'll get the phone calls. I saw your bus, or hey, can you come visit us or my area? If they call and we're not in their town, we give them the closest location where we will be. If we have a lot of calls coming from the same town, we say, hey, why don't we dig a little deeper and bring it to that specific town because it's obviously a needed service there.
Yeah, great. All right, now here's a general question for all of us, and it's a great question. Some clinicians see mobile health clinics as taking away their business. So they are not happy to see the mobile health clinics getting into their community. Any strategies to approach them? All right, so who wants to hit that answer?
I'll start. We've had this issue already in the past because we're giving a specific service, and there were facilities that were not happy seeing us within an eye shot of their own facility who offers the same service. So what do? As Linda Billy always says, we want to play nice in the sandbox, right? We're
Yeah.
able to move, to change our location, and that's what we want to do. We're not here to cause any enemies. The most important thing is that women are getting screened for our sake. Women are getting screened. Their follow-up, they don't even have to come to Stony Brook. So it's not even that we're pushing Stony Brook onto the patients. They get screened. So if we were in that area and we did move, and then they call us and they say, "Hey, you used to be here. Are you coming back here?" And we say, "That's an option. You could go to that facility, or here's our new location. We're still in the same area, but we're a little further away." If we have to stay there, or when it did come to a head, we contacted the facility directly. We spoke to them. We let them know, there's no ill intention, no ill will. And to circle back to the previous question, we do visit certain locations annually, 4 times a year, 3 times a year, twice a year. And we do have them as regulars, even monthly. Certain clinics we go to every month as regular visits on our schedule.
Yeah, I'd just like to add to your answer, Patrick, that for our van, we're not doing treatment yet. So, but we have actually had conversations with multiple physicians after we've screened their patients. So there's a continuity of care, and we're referring the patient back. And actually, it was received very well. But of course, we weren't stealing the patient and treating the patient at the time. But I think the answer to that question is communication, just like Dr. Deneen has pointed out. You just have to communicate. Yeah. Okay, Vaxmobile, you're up. So are you using New York State and/or CDC data analytics to target communities that have lower vaccination rates?
Yes, 100%. So we go, we're constantly looking at the numbers that are published by our health department. We've spent a lot of time in Hempstead. We've spent a lot of time in Elmont. So we do look at communities where the vaccine numbers are very low, 100%. And we go back, in the beginning where it was 2-dose. And so we had to then make our calendar so that every 4 weeks we were back at the same location. And the same was true for schools. I didn't mention that we partnered with a lot of our schools in underserved areas. And we were constantly going back every 3 weeks, every 4 weeks, so that just to make it even easier for parents to get the second dose. So the way that we structured our model was very much to make sure that we were always there. There was never any guesswork to be done. When they got their first vaccine, we gave them a card and said, 4 weeks from now on this date, you'll come back to the same time, same location. But to answer your question, yes, we definitely looked at data to target those areas.
Great, thank you. All right, so now I have a question that has 3 sub-questions in it. So thanks for the great introduction. I have 3 questions. How do you decide the locations of the mobile health clinics? Are the locations changed or optimized over time? How do you think of the overlap services between mobile health clinics and local hospitals? Some local hospitals consider clinics as competitors. And any suggestions on mobile health clinics deployed in rural communities? Angela, why don't I give you the first part of this question? How do you decide the locations of the mobile health clinics?
Yeah.
Yes.
So we're on a schedule that constantly evolves and changes. We are not at this point going back to locations multiple times, at least not in any kind of scheduled way, although we are looking to do that in the future. So we're pulling from a few different directions. We're looking for events and things that are already happening that we can become a part of because the people we want to serve are already going to be there. And we're looking for geographical locations that we feel represent the population that we want to serve, and finding community partners that we can partner with there. So a food pantry, or something that's happening that we can kind of invite ourselves to and become a part of, has been really successful for us.
Yeah. So the second part of this question is really dealing with the overlap of services like we talked about before, and hospitals seeing it as competition. And so does anybody have anything to add to that in terms of, playing nice in the sandbox?
I think you guys addressed it well.
Yeah, yeah. And then suggestions for mobile health clinics deployed in rural communities. Oh God, is that needed, right? Yeah.
So Patrick had mentioned earlier the Mobile Healthcare Association, and they do have information about this, and there is some research out there that you can find, and I know they have some on their website as well. I don't know, Patrick, if you have anything else.
There are other programs that were on the same grant as us. It was a 4-year grant up in Rochester, up in Syracuse, that have to take overnight trips. They're responsible for a much vaster plot of land than we are, with just 2 counties in Nassau and Suffolk, and they do things that we couldn't even imagine, with staying overnight in hotels and staying out for days at a time. So we could put you in touch with those programs. If I put my email address in the chat box, and we could link you directly to those programs who work in the rural communities.
Great, thank you. Here is a question for Malloy Community Care. Do you try to target communities that are food deserts, pharmacy deserts, and or medical deserts?
Yes. Yeah, I mean, we looked at the county. Both of the counties in Long Island had done community needs assessments multiple times over the years. So we refer to those with deserts, or just high incidence of uninsured, or whatever kind of indicators can point us to. But definitely, that's what we're looking for.
Right, or food swamps where they only have unhealthy food. Yeah, thank you. Okay, and Patrick, does your hospital require the women to have a script from their primary care physicians? If so, how do you handle it if they show up without one?
Good question. No script required. We do ask, for the most part, the women we screen, they're pre-registered. So we contact them prior. We have an idea of the schedule. We do take walk-ons. So you do not need a prescription, but you do need a doctor to list under the care that'll accept the results and then provide a diagnostic prescription if you need further workup in a different facility. For the uninsured women, who obviously are not under a care of a doctor, we provide that for them. So we provide the doctor, we provide the script for them if they do need the diagnostic follow-up.
Great. This is a great question for all three. Any advice on securing funding for a mobile unit? So why don't we start? Well, Dana spoke about getting the CARES money, right, from the county, correct?
Yeah, I will say there are definitely grants out there. I'm sure Patrick can speak to this. There are grants out there. Just keep in mind, if your grant is limited, if it's a 1-year grant, once that grant is up, it is very expensive. I mean, I definitely have a lemon. The bus has had a lot of challenges, so it's a big investment to keep it running when the grant runs out. But there are grants out there.
Yeah, and Angela spoke about us getting the grant, and Patrick was successful in turning your grant into a hospital run. Can you? Our time's up. Can you give like a 2-second? How did you do that?
Yeah, know your overhead.
Yeah.
Know what you can cut, know what you cannot cut. Know your true numbers, present that to the board. They'll know it's an undertaking. It's more of the socioeconomic impact you're making and the people you're helping that you can't see by dollars and cents. Although medicine is a business, you do have to make money, and it does bring in money, but you have to know that impact that you're making, and add that punch in your presentations to hit the heartstrings for
Okay.
them to decide to take you on.
Okay, great. Thank you. Thank you. We'll have to go through these slides, yeah. But we answered most of them. Okay.
Okay, thank you again, Dr. Ulrich, Angela, Dana, and Dr. Deneen for answering those questions, moderating, and for the great presentation. It was a pleasure to have you all with us. Before I conclude this webinar, I just want to remind all attendees, first of all, I want to thank you for attending and remind you that you will be receiving an email containing a link to a brief online evaluation. If you are requesting CE credits, you must submit that evaluation in order for you to receive a CE certificate. Visit the Health Literacy Solutions Center at that link to access the recording and presentation materials of today's webinar and to register for upcoming webinars. So with that, this concludes the webinar. Thank you all for attending. We hope you have learned and enjoyed this presentation.